Welcome to our HFA's first educational webinar of 2022. We're so happy to have you here. We'll begin introduction in just a couple minutes. As required in the Zoom age, we give everybody a couple of extra minutes to join, but we'll be respectful of your time and start at about 7:02 Eastern. As you can see, as you join the room, you have the ability to go ahead and chat with your fellow participants. But as this is a webinar, just for now, just a few of us will be on camera, and we'll get a little bit more into that as the presentation goes on. It looks like HFA's virtual symposium back in October has trained everybody very well to introduce themselves in chat. It's a feature that I love very much. So if you're here, please go ahead and introduce yourself and welcome everyone. But seeing that we've got a bunch of people, I'll go ahead and get started with the introductions, and we'll dive right into it. So thank you everyone for joining tonight. Just wanted to let everyone know that this session is being recorded, and we'll be able to post it later this week for your viewing then too. This session is reconstructive surgery for advanced hemophilic arthropathy. Tonight's session will last for 1 hour from 7 p.m. Eastern until 8 p.m. Eastern, and HFA is honored to have Dr. James Luck Jr. to present this session. Before we begin, I would like to take a minute to thank the HFA sponsors. After introducing HFA very briefly, we're founded in 1994 as a national nonprofit association that assists, educates, and advocates for the bleeding disorders community. And we are very grateful for the sponsorships that are offered that specifically cater to this webinar and allow this to be possible. So thank you all. So as a reminder, all attendees will be on mute throughout the session. There will be time for Q&A at the end of the session. So I and a couple of other people behind the scenes will be collecting questions for Dr. Luck as we go on. Please go ahead and use the Q&A box at any time for questions. We'll go ahead and leave the chat box open for communication between the participants. But if you'd like to ask Dr. Luck a question, please go ahead and put that in the Q&A box at the bottom of your screen. If you have any technical difficulties and need to speak to an HFA staff person, please put your concern in the chat box. And please be aware that this presentation does include graphic images of surgeries. So perhaps nothing that this community is not used to, but please do be aware that there are graphic images. And finalmente, esta sesión está disponible en español. Haga clic en el globo terráqueo en el parte inferior de la pantalla y seleccione español. So thank you. I'm going to stop sharing. And Dr. Luck, please feel free to take the screen. So thank you so much for joining us, Dr. Luck. You are all set to begin.
So to those in the Western US, good afternoon, and the rest of you, good evening. Thank you so much for inviting me to talk to you about reconstructive surgery for advanced hemophilic arthropathy, a topic very important to all of us. Tonight, we'll talk about joint replacement of the knee and hip, a little bit of an introduction about pathophysiology that I think most of you are familiar with. And then really importantly, we'll talk about prevention of infection. And the problem, one of the main problems with hemophilic arthropathy is arthrofibrosis, or development of scar tissue and limited range of motion. These are very important issues. We'll just sort of touch on the arthrofibrosis, and then at some point in the future, if you wish, we can talk about the elbow, ankle, and more on arthrofibrosis. And a new device that we are developing to give you biofeedback on your range of motion. So tonight, we're just going to do the stuff on the left. In terms of conflicts of interest, these are my disclosures. I don't believe any of them represent any conflict to the material of this presentation. So as some of you know, Orthopedic Hospital Hemophilia Treatment Center was one of the first two in the country, perhaps the first. And with the advent of clotting factor concentrate in 1966, it became possible to do elective surgeries. Prior to that, it was really only emergent, absolutely essential surgeries. And since that time, we have done a bit over 1,500 reconstructive surgeries for hemophilic arthropathy. So here's the problem that you all, unfortunately, are all too familiar with. This is a young man with a large hemarthrosis. The normal knee can't hold that much, but what happens is, as the knee continues to have bleeding episodes, the capsule expands like a balloon, and it gradually gets bigger and bigger, and it can hold more and more. So this is the X-ray at that time. The growth plates are still open, the young man, and really the X-ray looks pretty good. He's got a pretty good, what we call joint space or cartilage interval. The thickness of the cartilage looks pretty good. And most of the time we'd look at an X-ray like that and say, well, good, it's not too bad. Well, that's not quite the whole story, unfortunately. So here is the knee on the right, and this is my one graphic image for those that are a little bit touchy. The same patient, the same young man, adolescent. What's happened is the joint surface cartilage has been severely eaten away by the synovial membrane, this very brown stuff. And the reason it's brown is because of blood pigment. The synovial membrane's job is to clean up the joint. It's also a job to make the synovial fluid to lubricate the joint. Well, in order to clean it up, it has to absorb or take in all the red blood cells and the broken down products of red blood cells. And that's what we see this brown stuff is. The white is the surface of the synovium, and then right underneath that surface, if you look at this channel right here, can you see my pointer, by the way? Usually you can. Anyway.
Yes, we can. Thank you.
Good. So is a vein, and it's greatly dilated. So the synovial membrane, as it gets thicker and thicker to try and do this job of removing more and more blood, its blood supply increases. Well, this membrane becomes very fragile, and there are grossly dilated blood vessels right under the surface. So all this patient has to do is bend his knee, and these rough, irregular surfaces will open the synovium, it'll bleed. So even with normal clotting factor, it's still going to do that at this stage. So the treatment for that is a synovectomy. I think you're aware of that. And there are various types of synovectomies: arthroscopic, radiosynovectomies, open synovectomies. Those should be done long before the knee gets to this point. Now, a lot of that could be avoided if the patient is getting adequate amounts of clotting factor early on, possibly Hemlibra or something like that. And then maybe you reverse this process before it gets anywhere near this stage. And it's a vicious cycle. As the knee bleeds, more synovium thickens and forms, and it bleeds much more easily, and then gives rise to what we just saw. All right, enough of the graphic pictures. So advanced hemophilic arthropathy, the situation starts to change. The knee or joint doesn't bleed as much. The thickened synovium changes to scar tissue. And that's what you see there. This is a knee open at the time of knee replacement, just the same picture you just saw, the same exposure, but you don't see the synovial membrane. You just see this dense scar tissue that's formed inside the joint, and that's arthropfibrosis. And that is a unique and fairly severe problem with patients with hemophilia. And as I'd mentioned, we've done some research on that we could go into perhaps at another time. But that represents a major functional limitation. The painful joint, yes, is a functional limitation, but if it's as stiff as a board, it's much worse. It also results in deformities. Here you see this knee is almost dislocated. And a lot of muscle atrophy because this patient was unable to effectively use his legs. That's an old picture. Again, stiffness, severe limitation of range of motion. This is a young man, but again, years ago, and I think we would not have to deal with that very often today. But with foot and ankle, with ankle arthropathy, yes, it does at times develop severe contractures and what we call an Aquinas deformity because the foot represents that of a horse. It's pointed down. And as you can see, this knee, which has advanced arthropathy, has no cartilage interval, no joint space, bone on bone, and almost no motion. The synovial membrane can at times invade the bone and destroy large parts of the bone. These are large synovial cysts on both sides of the knee joint. That poses some additional challenges with reference to the surgery, but they're challenges we can meet. And then we talked a second ago about deformity, rather marked deformity. This type of deformity, again, requires an implant that will straighten the knee, but also give stability to the knee. And we have those. Okay, bone loss. So in this particular patient, the kneecap has migrated over to the outer side of the knee, and it has eroded down part of the femoral condyles. So we take bone graft. At the time we're doing the knee replacement, we have a chance to remove some bone that we have to remove anyway for the implant. And we can use that as a bone graft to reconstruct areas where the bone has been lost, and that incorporates well. So Dr. Silva and I reviewed our knee replacements from 75 to 2001, one of the largest series in the world. Total knee replacements, 90 in 66 patients, followed for at least 2 years, but up to 25 years. Well, 8 to 25 years. So 46 of these knees were bilateral. And as you all know, the knee problem in hemophilia is frequently bilateral. So we'll look at the results of that study. These are young patients who need a knee replacement for the reasons we discussed: early onset, recurrent bleeding, synovitis, joint surface destruction, even in adolescence. So the age range on these patients, the median is in the 30s. So that poses some additional problems because now we have to have a knee replacement that we would like to have last the patient the rest of their life, if at all possible. They can be revised, certainly we do that. But ideally, one time would be great. And we're going to talk about some of the research that has enabled us to make much longer lasting joint replacements. We'll do that further on in the talk. 93% of the patients were severe, 67% were HIV positive. And look at the range of motion that pre-op, the average range, the average flexion arc of the knee was 57 degrees. Post-op, it improved some, not great, to 68, and at the latest follow-up, 72. 72 is a lot better than 57, and most of the patients thought it's okay. But if you take other populations, not hemophilia, rheumatoid arthritis, osteoarthritis, post-traumatic arthritis, they usually get 120 degrees. Now, some of our hemophilia patients got 120 degrees, and those were the ones that did not have severe arthrofibrosis. So the arthrofibrosis is a really, really important factor. So in terms of results, excellent and good results, 97%. Well, we're very happy with that. That is as good as any series of knee replacements in non-hemophilia patients. One poor result. The one poor result, and this is functional score we're talking about now. We'll talk about durability in a minute. Functional score, One poor result, 3%. If you look closely at this X-ray, you can see that the thickness of the plastic liner, high molecular weight polyethylene, the plastic liner is getting thinner here. And it's getting down to the point where the metal surfaces, the tibia and femoral metal surfaces, can almost touch. We didn't like that. We started revising that. He said, no, it's fine. He didn't want another surgery. So that was okay. But again, we're going to talk about what can be done to make these implants last longer. All right, here is perhaps the most important part of this particular research. So if you look at implant survivorship, mechanical survivorship, 96% at 20 years, great. But if you look at patients who needed further surgery for any reason, the survivorship drops to 82%, 82.7%. Now, what accounted for that difference? Infection accounted for that difference. Really, really important in patients with hemophilia. So there were 14 knees in 10 patients that became infected. That was 16%. That's a high number. And within the bilateral knees, it was 22%. And it happened anytime between 6 months and 25 years later. That's an important number. So it can happen at any time. The mean length of time from surgery was 5 years. So these were not postoperative infections, which are thought to occur within the first 6 months. These were late infections. They were successfully treated. Some of them could be treated by just a good washout, surgical washout. Two of those 7 had persistent infection. Those patients, and most of the patients with implant infection today, require removal of the implant, get rid of the infection, and then put another implant back in. There is a temporary implant that can be used that gives off antibiotics, and they work pretty well. But you're talking about 2 additional surgeries at least, and a lot for someone to have to go through. We looked at whether or not HIV made a difference in this series. And the incidence of infection in the HIV negative group was 13%, and the HIV positive group was 17%. Those statistically are not different. So there was not a significant difference between HIV positive and HIV negative. And we'll get into more of that in a minute. The CD4 count did not seem to matter. And this is important also in the future. Whether or not the patient was infected or non-infected, the CD4 counts were the same.
Dr.
So
Luck,
what can we do?
I don't mean to interrupt here, but I think we have a time-sensitive question. And there's a couple of questions about why the infections occur overall.
Do we want to, do we want to, and we're going to get to that. That's this next set of slides.
Then we'll wait.
But do we want to hold the are the questions or have them as we go?
We'll wait. My apologies.
And how are we doing time-wise?
We're doing perfect. It's about 4:18 Pacific.
Let's do this. If someone has a question they really like answered, then let's do it. Otherwise, we'll roll along, because some of the questions are going to be answered as we go along. And that's this next group of slides. This was some research that we did. So in the future, if we can solve the problem of wearing out implants, the primary mode of failure is going to be infection for all patients. That's going to be the #1 risk. But it's much more common in patients with hemophilia. When it happens, it's a very serious complication. We've talked about the fact, multiple operations, prolonged disability and discomfort, high cost, more in hemophilia. So obviously, prevention is the key. I looked at some early articles. Dr. Ragney published a series, a survey series that she did of 115 HTCs with procedures on patients with hemophilia, of which 34 were total joint replacements of the hip or the knee, And all of those patients had CD4 counts under 200. The infection rate within the first 5 months, so these are early infections, these are not late infections, 26.9%. That's huge. Thomason published an article in '99, 23 total knee replacements, 4 infections, all HIV positive. At this point, the hemophilia community, the medical community said, aha, the reason for this increased risk of infection is immune suppression from HIV. Well, I just showed you our research, which was published after this, tended to raise a question about that. So if we look at later articles, you know, all of these articles, including ours, the incidence of infection,
La incidencia de infección.
the incidence of infection is
Incidencia de infección.
still pretty high, with one exception, Dr. Goddard. And I don't know why this is, other than his patients are English, and I have sort of a theory that we could talk about, but he was only 1.4%.
Fue solamente 4%.
So if we also just talked about our series, rate of infection of 16%, one of the higher ones. So if we total it all up, 556 joint replacements with an average follow-up of 7.6 years, with an average rate of infection of 8.6%. But here's the key. There was no difference between the HIV positive and the HIV negative patients. Now compare that to infection rates in non-hemophilia patients. And total hip replacement is about 1%, total knee replacement's about 1.5%. These are huge nationwide database studies, and there's a dramatic difference between
Hay una
hemophilia
diferencia dramática.
and non-hemophilia. So I have a question for you. If the problem isn't really HIV, what is it? Why do patients with hemophilia have an increased rate of infection? Anybody want to hazard a guess? On chat? Okay, I'll tell you. The thing that separates the hemophilia patients from the other patients is frequent IV self-infusion. Now that's starting to change with Hemlibra and some other agents, but during this whole period of time was something that happened frequently. And so our question was, could that be introducing bacteria into the bloodstream that then would go to the knee or hip? So we started a study of patient education on excellent IV self-infusion technique. And we began preoperatively. We told them of the high rate of risk of infection and that might relate to IV self-infusion. We reminded them at every visit. They were trained in the technique by our nurse practitioner, Chris Chen. It was a meticulous technique that they were trained in. And we did a prospective study of joint replacements from 2005 to 2017. So there are 49 total joint replacements, 39 knees, 10 hips, with a mean follow-up of 6 years. We divided infection into 2 groups. The primary infection is an infection, a bloodborne infection without a known source. So that would include IV self-infusion. In other words, the patient just shows up one day with an infected joint and we don't know where it came from. Secondary infection is a joint infection with a known source, where something happened that showed us where that came from. So in this series, the number of HIV positive patients is less, as you would expect, with much better management. So dropped from 70% to 34%. Average CD4 counts, though, in this new study group actually were less. And the demographics of the patients were the same. So if we look at early infection, that's the first 6 months. That's where Ragni's study had this huge number. There were none in either group, no early infections. We've been fortunate in that regard. Primary infection, again, infection, bloodborne infection, don't know an exact cause, maybe self-infusion. 16% in the previous study, 0% in this study. Secondary infection, whoops. Let's go backwards. Secondary infection, there were 2 in the new group, and we're going to talk about that. The first is a patient with hemophilia A severe HIV negative, severe arthrofibrosis. So he had his knee replacement. The knee tended to lose motion from the arthrofibrosis. He had arthroscopic and open debridements, multiple procedures. 2 weeks after one of the surgeries, he fell, opened up the wound. That developed an infection which infected his knee. The implant was removed, the knee was washed out, a new one put in, and he's fine at this time. And it's been now about 12 years, I think. The next patient is hemophilia B, severe HIV positive. So I have 1 HIV positive, 1 HIV negative. Left total knee replacement in 2009, developed an infection of his elbow, did not have an implant, just an infection of an arthropathic elbow with an organism called beta strep. 2 days later, his total knee blows up with the same beta strep. So we know where that came from. That came through the bloodstream from the elbow to the knee. The knee was treated, we got it early, fortunately, treated with washout, and the elbow was treated open with an open washout radiohead excision, and he's fine. And it's been now quite a while. Well, gosh, 9 years. So let's talk a little bit about cost. The cost of these infections is very high. So the secondary infection, and this is cost, this is not hospital charges, this is actual cost. $304,000, the case 2, which had more procedures, $643,000, okay? Now here's another one. This is a patient who was referred to us with already an infected total knee and a total shoulder, who had an inhibitor. And as you all know in this audience, the cost of managing inhibitors is much, much higher. And he required many hospitalizations, removal of the knee, partial removal of the shoulder, multiple washouts. He required a venous access port. And those are a problem because they can get infected and frequently do, and then that can infect the implants. So it was a big deal, multiple hospitalizations, and you might take a wild guess what you think his hospital cost is to date. Over $11 million. So prevention of infection is crucial. And good technique with IV self-infusion is one of the things we can do to help that situation for our patients with hemophilia. Study limitation, the number of patients. all hemophilia studies have that problem. We just don't, fortunately, aren't that many. It's a rare disease. And in conclusion, we can say that a protocol-driven patient education in IV self-infusion can significantly reduce the rate of infection with minimal cost and potentially saving of billions of dollars. Now, new therapeutics that avoid IV self-infusion, great. We're going to move on to the longevity of hip replacement, and then there should be time for questions. We obviously have multiple authors in this study. We talked before about what we can do to make implants last longer. Hips have been more of a problem that way than knees, but you saw one example of a knee that was wearing out. So this happens to be the first joint replacement on a patient with hemophilia in the US, and was done by my father, who had the same interest I have. That's probably where I got it, in a hemophiliac in 1968. And that's That is a sort of hip replacement. It's not a modern hip replacement. It's called a cup arthroplasty, but it was what we used at that point in time. So looking at the early results of cemented hip replacements, and hip replacements can be fixed with cement or fixed with a bone ingrowth implant. Same with knees. Hips today are almost all bone ingrowth. Knees are almost all cemented. And there are some reasons for that, but we don't need to spend a lot of time on that part of it. But look at the failure rate. R series, early series, 33%. Kelly's series, 41%. Nelson series, 36%. Some infections. But the big issue was failure of fixation of the implants. The implants work loose. They were put in with cement and they work loose. And they seem to have a much higher failure rate in hemophilia patients, even without infection, than in non-hemophilia patients. But non-hemophilia was also had the same problem. So here's an example. Here is a patient with hemophilic arthropathy of the hip. You can see the erosive changes of the femoral head. The cartilage interval joint space is narrowed. This is a early total hip replacement put in. The wires surgical approach involved taking off part of the bone and putting it back at the end, and that's what the wires are. And then you look here at a follow-up X-ray that wasn't very far down the road. That implant is loose. There's a dark area between the implant and the cement. The white stuff's the cement, and it has lost its purchase. If the implant works loose, it's painful and it has to be revised. So at that point, people decided the problem was the cement. And the solution was to avoid the cement. So here's another example, this one where you see there is this dark area between the cement and the bone. That's all membrane. That's a loose implant. That's where the bone has been eaten away from the cement mantle and the stem. So they thought porous coating would be the solution. Well, it's worked great in the knee. So they started doing porous coated hips. But look here. This is a porous coated implant, no cement on either side. But look at the bone. The bone is very severely eroded and expanded, and on both sides, both the pelvis side, the acetabulum, and the femoral side. So obviously the cement didn't have any. So then what is the problem? Another example, cementless implant. This is a series of cases. And if you look at the X-rays, you can see the bone is gradually melting away. Here it's partially gone. The bone should be up from here to here. A little further along is down further. The trochanter, this part of the proximal femur where the muscles attach, is beginning to look like a ghost. Here is completely gone. The pelvis side is severely eroded, and about half of that femoral stem is now exposed. So all that bone has been taken away. So what caused that? It wasn't cement. There was no cement. So what is the mode of failure? Well, here it is. This is an implant that's been removed from a patient who has, severe, we call osteolysis, loss of bone, and loosening of implant. The femoral head originally fit very closely in this liner of the socket that goes inside the pelvis. Here it doesn't fit closely at all. It's wearing through the plastic. That was the problem. Polyethylene wear. The plastic is called ultra-high molecular weight polyethylene. That causes osteolysis of the bone. And that causes failure of fixation because if the bone is eaten away, there's nothing to hold the implant. And loosening of the prosthesis and need for a revision. This was the first wear test simulator to look at new materials. It was developed at Orthopedic Hospital by our research director, Harry McKillop. It could create an environment that replicated a total hip replacement wear of the metal ball against the plastic with synovial fluid, and they could replicate a year and a month. So it all the time. So that was crucial in this research. What they found was that 1/10 of a millimeter of wear. So the plastic, you saw that the previous picture, it was a lot more than 1/10 of a millimeter. It was several millimeters. So 1/10 of a millimeter wear on average resulted in the generation of 500 billion particles per year. 500 billion. The reason there can be so many is the particles are very tiny. They're submicron. You have to have an electron microscope to see them. They're really small, but that's bad because they can easily get in between the bone and the implant, and then cells that the body sends in to get rid of the particles can't digest the particles, so they digest the bone. The average person takes 1 million steps a year. If you do simple math, that results in 500,000 particles per step of conventional polyethylene, the old stuff. So here is a graph showing wear, that same wear I just told you about, over time. It's typically linear progression of wear. And here is that same material, but now the polyethylene molecules have been cross-linked. They've been joined together, initially with peroxide, later with radiation. But the bottom line is those molecules are now joined together much more closely than they were here. And look what happened. Nowhere. Now with radiation cross-linked, we use 5 megarads. By the way, that radiation has nothing to do with you. The implant it has no residual radiation when it's put in. This is just a means of getting the molecules to join together. So we took that information, and it now is becoming I won't say the total standard around the world, but widely used throughout the world. And we reviewed the literature, and we wanted to see if there was any articles on patients with hemophilia with the use of the highly cross-linked polyethylene and whether that had helped with that early failure rate that we all saw. So we had 17 patients with 19 hips. Again, hips, not knees, because hips were more of a problem with wear than knees. Hemophilia B6, A11, no inhibitors. HIV positive, 6 out of 17, about like our current percentages. CD4s all over the landscape. HCV positive, most of the patients. Study period from 2002 to 2018. So we have a mean follow-up of 10.5 years. The mean age, a little later than the knee replacements. Mean age of 57, that's typical of hips. And 4 patients died in the study of unrelated causes. So our standard factory replacement regimen, bolus and continuous infusion to 100% the day of surgery, and then gradually decreasing over the hospital period and follow up with physical therapy. But we maintain a trough of 30% for the first 2 to 3 weeks. All the stems and acetabular shells were porous coated, no cement. J&J DePuy was a manufacturer. Acetabular liners were all highly cross-linked, ultra high molecular weight polyethylene. Single primary surgeon, posterior lateral approach. Postoperative x-rays were compared to most recent x-rays. We were looking at linear wear of the acetabulum, the acetabular polyethylene liner, that thing you saw that was worn badly. We were looking at linear wear. We were also looking at loss of bone, called osteolysis, both on the femoral side, on the acetabular side. So a couple of cases demonstrating pathology. This is a patient with advanced hemophilic arthropathy early in life, so his femoral head never develops. Here's the normal side. It's not entirely normal, but it's a lot better. This side has almost no femoral head, was treated with a hip replacement, but the acetabular part is a mobile bearing, not porous coated. and the femoral stem is porous-coated. So intraoperative complications, there was one fractured femur that was plated. Patients with hemophilia do have a little more osteoporosis. Postoperative complications, none. That healed well without sequelae. No blood clots, and very rare in hemophilia for them to have problems with blood clots, but it has been reported. No infections, which we're very thankful for. No revisions. Additional operations for any reason, no. So acetabular liner wear, none. Acetabular osteolysis, bone loss, none. Femoral osteolysis, none. So we concluded that in addition to prevention of infection, highly cross-linked polyethylene will improve the longevity of total hip replacement in patients with hemophilia. Same limitations before, relatively small number of patients. So that is the end of my presentation so far. It's 4:40. By gosh, we're right on schedule. How about that? This is the Orthopedic Hospital Research Center that we built with UCLA on the UCLA campus. And the reason we did that is because it is in the court of sciences, and there are all kinds of other scientific research going on all around it. You know, genetic research, nanotechnology research, all kinds of stuff. And we can collaborate and we can do projects. And most of the projects we do today are collaborative projects. We do a lot of work in molecular biology, genetic stem cell, and as I said, collaboration. And our current structure, you see Orthopedic Hospital. We have sold that part and built a large complex. And we also have the research center. We have a new outpatient center, relatively new, and we have the Orthopedic Hospital Medical Magnet High School for inner city children interested in healthcare. And this is the Santa Monica UCLA Medical Center and Orthopedic Hospital where we do our inpatient care. So thank you very much for your time and attention. I'll look forward to the questions.
Thank you so much, Dr. Luck, for sharing your time and expertise. We've had a few questions rolling through the chat, but wanted to apologize to everyone. We had a little bit of translation bleed into our main presentation, so that was our technological issue. So my apologies for that. So I'm reviewing the questions. We've got a few coming in. If you have a question for Dr. Luck, please go ahead and ask that in the Q&A section of the chat. Some of them we will have covered so far. But our first question comes from somebody with type 3 von Willebrands. They have a question about knee joint replacement and how long is the recovery and how do you have to prepare for it?
Okay, it's an excellent question. Yeah, type 3 is pretty similar to hemophilia, really, and in terms of the orthopedic situation. So several key factors here. What is the range of motion now? Does the patient still have reasonably good range of motion? If they do, the recovery is going to be easier, and maintaining that range of motion is going to be easier and more successful than if they go into it with an extremely stiff knee. Even the patients go into surgery with an extremely stiff knee, things can be done, and we are working on a new approach to that, that reduces the chance for the arthrofibrosis to attach to the implant. So we're hoping, we have some early results, but we're hoping that will get better range of motion for the extremely stiff knee, and these were patients with essentially no motion. Obviously, prevention of infection, meticulous sterile technique with IV self-infusion, reporting any possible sorts of infection right away to your physicians, prophylactic antibiotics before dental work to be sure that you don't get bacteria from your mouth into your bloodstream, and I'm going to be talking about that at WFH. Lots of things you can do in that regard. Get your muscles as strong as you can before the surgery, and that will help you with your rehab. And the results are excellent. It's not the easiest surgery in the world. Knee replacement it's kind of a painful surgery and working with the rehab, but it's well worth it. And the end results are outstanding.
Dr. Luck, the questions are coming in pretty quickly right now. You've hinted that you might be able to have a follow-up webinar with us at some point in the future. So perhaps we can collect that data and get back to you later. But we'll try to cover as many as we can in the next few minutes. For a bone graft, where does the donor bone come from? The same person's body, cadaver, or other?
Same person's body. Usually local bone. In other words, when we put an implant in, we have to take some of the existing bone away to accommodate the implant. And we can use, we can usually use that bone.
Great, thank you. We've got questions about infection, but I believe you answered those very well already. So this one is a little bit of a longer one. I have significant ligament damage, bone on bone, for 2 decades, and also immunocompromised after a transplant, along with being hemophilia A severe. I'm hoping to delay a total knee replacement 1 year at a time, ideally forever. Is that a good idea? When will it be too late for TKR?
I don't think it's ever too late. If there's ligament damage, can be corrected at the time of surgery. That's not much of an issue. The immune suppression, I think, it is probably an important consideration. And that's something you need to talk to your transplant patient. Has had a transplant? Yes?
Yes.
And kidney, lung, what?
Kidney.
Kidney, okay.
I think so, I know who this is.
They've improved greatly in terms of managing rejection and things like that. So talk to your doctors. I don't think it is necessary to completely eliminate the possibility of knee replacement, but there may be some increased risk because of immune suppression. And the answer to that, I think, in addition to being really, really good with your IV self-infusion, is just if you do have a knee replacement, take excellent care of yourself. See the doctor right away if there's any sign of infection, and I'm sure you're doing that anyway. So yes, I think it is possible.
Great, thank you. More questions on infection, but we've got those. How often do you see port placement in adult bleeding disorders patients?
Would you mind repeating that?
How often do you see port placement in adult bleeding disorders patients?
Oh, hopefully never. I've done one. The one I mentioned came from elsewhere. I really try to avoid the ports. Now that we've got Hem Libra and stuff like that, it's making a big difference. We may have something good like that for hemophilia B. I think ports are high risk. I'll do it, but only after a lot of patient and family education, a lot of soul searching, so they really understand how important it is to take really good care of that port.
Perfect, thank you. After a TKR surgery in hemophilia B patient, how soon should they be able to start walking?
Right away. So the standard approach, if the patient feels like it, is to get up that evening or the following morning and start walking. How much motion we allow in the knee early on depends on some technical considerations, wound healing, etc. So they may be walking in a knee immobilizer, but they are up out of bed, walking with a walker easily within the first 24 hours.
Thank you. Can a joint debridement surgery delay a necessary joint replacement?
Not very well. We did a bunch of them. We published, and other people have published articles on it. It's kind of iffy. Arthroscopic debridement sometimes helps for a period of time, but if the joint has pretty advanced changes, if the articular cartilage, the joint surface cartilage, is pretty badly eroded, it's probably not going to. If it helps, it'll help for a very short period of time. It's probably not worth it.
Thank you. If infections are caused by self-infusion, shouldn't prophy patients who don't get replacements also get infections?
Yes, and I think they do, but not as frequently. So if you get bacteria in your bloodstream, your body can normally fight it off pretty well. We know you get bacteria in your bloodstream when you brush your teeth, for example. But rare do people get infected, but maybe they get a total joint infected. What's the difference? The total joint is a sitting duck. It can't defend itself. So if bacteria get in the bloodstream, they'll get into the synovial fluid. They get onto the implant. The implant has no white blood cells. It has no antibodies. And there it sits, and the bacteria gradually build up till they have a full-blown infection.
Thank you. Someone with hemophilia 9, mild, total reversed shoulder replacement. How relevant is the brand and manufacturer of joint in today's marketplace?
I don't think I can answer that. A faculty member who I work with a lot at UCLA, who loves reverse total shoulders. He really thinks they're a great answer. Technically, very demanding surgery. I don't know the details about which implants are favored. His name is Edward Chung, Cheung, at UCLA. If you would want to write him or email him or something and ask his opinion, I'm sure he'd give it to you, even if you're, a long ways away and having surgery elsewhere.
Thank you for that. Curious on your thoughts about options to manage an ankle with significant hemarthropathy.
Yes, I do. And we might have some time to talk about that at another session. The big debate, and I think we're getting answers, but the big debate is fusion versus ankle replacement. Fusion is a long-term reliable solution that gives excellent results and excellent gait, ability to walk. Ankle joint replacement has good early results, but again, you're dealing with an implant that can get infected, and you're dealing with implants that are very small. And if they work loose, they don't have good fixation. They don't have a lot of bone attached to them. And so the failure rate for total ankles, currently at least, is pretty high, higher than current rates for knees and hips. So personally, I strongly favor ankle fusion.
Okay. Thank you. I know that was a question that's come up many times in conversations before.
Yeah.
We'll be answering questions for another 5 or 6 minutes. Thank you again for Dr. Luck, and then we'll be closing out. So how long is the rehab for total knee TKA for someone with severe hemophilia B with inhibitors?
Aha, so inhibitors are another topic. Now, we have started doing elective total knee replacement on patients with inhibitors on Hemlibra, and we've been very happy with the early results. Looking at just rehab of a total knee, you've got to figure 3 to 6 months, depending on how stiff the knee is going into surgery. If the knee has pretty good motion, maybe 100, well, it's unusual for a hemophilia patient to have 120 degrees of motion, but if they did, their rehab is going to be easier. I'm not going to say it's easier. If the knee is stiff going into surgery, it's going to take a lot of work to get a decent range of motion out of it. And you're going to have to work at it for a long time. So minimum 6 weeks and more likely 3+ months.
Great, thank you. How long after a total joint replacement should you take antibiotics for dental or other procedures?
Permanently.
Permanently.
Now that's a difference from non-hemophilia patients. But the concern about hemophilia is you can have microbleeds where that bacteria from your mouth can get down around the implant. And so we recommend that permanently. The dentist may say, well, the guidelines say only the first 2 years. That's for everybody else. That's not for patients with bleeding disorders. So permanently. It's 1 dose of antibiotic. It's the risk of taking that 1 dose of an antibiotic, unless you have an allergy, of course, which you should know, but the risk is minimal. And if the implant happens to get infected, it's a big deal.
Thank you. We've got, would love to hear more about procedures in the elbow. I have a big issue with my elbows and am also paraplegic.
I'm sorry, a big issue about the elbows, and
I am also paraplegic.
Paraplegic?
Yes.
So paralyzed lower extremities. Okay. So yeah, elbows really, really important, especially for everybody, but especially for that patient, my goodness. And they can be a big issue. Elbow replacement versus elbow radial head excision debridement. We favor the radial head excision debridement for the same reason as the ankles. Elbow replacements have not held up particularly well in hemophilia patients. And here is someone who's using their arms to propel themselves on a wheelchair. So the forces on the artificial elbow fixation, implant fixation, are going to be much bigger than you or me. So really, really important. There are other procedures that we favor far more than elbow replacement, and we'll touch on that another time, perhaps.
Thank you. We'll have time for, I think, 2 more questions here. A bleeder, this is the question. A bleeder shared with me many years ago that, quote, if you have major bone loss, most likely you cannot get a knee replacement. Is this true?
No, it's not true. No, fortunately. No, we mentioned that briefly, but we now have implants that can replace as much bone as we need to. We even have implants that can replace the entire femur if we're doing a tumor patient or something, and the proximal tibia. So yeah, no, it does not prevent that procedure.
Thank you.
There's another advantage of these extensive implants. I wouldn't recommend them unless they're necessary for bone loss, but the other advantage is the scar tissue can't attach to them, and the patients get better range of motion. So,
Thank you. We've got last question here. Someone with factor IX severe, constant pain and negligible motion with the need of a left ankle replacement, 41 years old, a tractor trailer driver. What advice would you have for me?
Well, I'm impressed. You're a tractor trailer driver and your knee has barely any, very impressive. I am Germani and I have trouble driving. So anyway, no, again, you've got very limited motions, a modified procedure in a good motion, maybe a little more bone removed, a little more implant in your knee. And
I'm sorry, I'm saying that it's actually an ankle issue. It's not a knee issue.
Oh, it's not a knee. Okay, so refresh my memory. What's the ankle issue?
Let me find that. Let's see. Factor IX severe, constant pain and negligible motion with a left ankle replacement, 41 years old.
Okay, revision of the left ankle replacement, without question. It may require bone graft because you're going to lose some bone because they had to put the implant in, but that can be done and it can be successful. And a fused ankle in the vast majority of patients is pain-free and highly functional, strong.
I think that we've got just a couple questions left, but I think that they might branch off into some potential future topics. So we'll go ahead and call that here. Dr. Luck, just incredibly grateful for your expertise here. And thank you for your informal office hours in answering all these very specific questions. So thank you so much.
It was my pleasure. It's a great group.
Thank you. So thank you all for attending our presentation, Reconstructive Surgery for Advanced Hemophilic Arthropathy. As we wrap up our time together tonight, I would like to take some time to introduce HFA's Associate Director of Education, Shelley Horowitz, to discuss our next monthly educational webinar. Shelley?
Thank you. Sorry, I had to unmute. I am really excited to tell you a bit about our webinar for next month. It will be on February 8th, same time, but a half an hour longer. We're going to go from 7 to 8:30 p.m. Eastern, 4 to 5:30 p.m. Pacific. And the topic is barriers to diagnosis, women with X-linked diseases. So in the bleeding disorders community, that's hemophilia A and B. And our speakers will be Dr. Rebecca Spencer. She's an anesthesiologist who has done extensive research on X inactivation. And we will have Taylor Kane. She is founder of an organization called Remember the Girls, which looks at women who are carriers of X-linked diseases and their struggle with getting treatment as they manifest those diseases. And then our final speaker will be Kristen Angel, who is a part of NORD, the National Organization for Rare Disorders. So we look forward to seeing you there, and you can find more information about this amazing webinar online.
And specifically in the chat, there is a link to go register. So thank you, everyone. And please feel free to attend. And just on a last note, about 20 thank yous in the chat just rolled through for you, Dr. Luck. So again, thank you for your time, and hope everyone has a fantastic rest of your evening and the rest of the month.
Thank you all.
Thank you all. Goodbye.